to you all in the audience. My name's Liz Heath. I'm a consultant with LaingBuisson, and I'd like to welcome you to the latest in our series of webinars. This morning's is around the topic of transparency, thrive, not to survive. We're moving into an era of greater clinical transparency, and we're going to explore how healthcare organisations can harness information to drive safer and more consistent patient outcomes. We have a number of very distinguished panellists who will discuss increasing transparency in healthcare and how we can embrace that to deliver better standards of patient safety. And also the increasing and evolving move towards transparent relationships with clinicians and hospitals. So I'm just going to very briefly start by reflecting on my very long career. When I joined the NHS in the late 70s, transparency was a word you applied to windows. There was no clinical transparency as we now know it. It was exceptionally hierarchical. Everything was designed to preserve the status quo. Patients rarely questioned their treatment or their doctors. Multidisciplinary team working simply didn't exist. And the referral relationships were very different to the way they are now. We've moved a long way, and we've moved quite a long way in the last few years, but is this direction of travel and pace sufficient for the future? I'm going to hand over initially to Dr. Clare Morgan from the Cognitive, who's the Medical Director of the Cognitive Institute, who will kick us off in our panel discussion. We're going to hear from our speakers, and then afterwards it'll be open to questions from the audience. Thank you, Clare.
Thanks so much, Liz, for that introduction, and thank you everyone for the opportunity to speak with you today. As Liz indicated, I'm the Medical Director of Cognitive Institute, and we're an organisation who's part of Medical Protection Society. We train and coach healthcare workers and leaders from hundreds of organisations across the globe through our communication and culture change programs. Through this role and my previous clinical roles and my medical leadership roles over many years, I've had the privilege of working with thousands of doctors at all stages of their medical careers, and to be inspired by their clinical skills and their passionate dedication for safe, quality patient care. Over this time, I've really come to appreciate that the real engagement work with doctors and the key to successful organisations is really about safeguarding and enhancing medical professionalism. By this, I'm talking about the skills and the behaviours that are enshrined in the codes of conduct that are used by our training and professional development curriculums and upheld by our professional and regulatory bodies such as the GMC. And I'm talking about the way we deliver evidence-based patient care, how we deliver patient-centred care, how we work together as colleagues, how we work ethically, how we're expected to commit to lifelong learning and reflective practice. Indeed, this professionalism is the driving force at the heart of every doctor that enables the delivery of excellence in care. Liz, you talked about the increasing need for transparency, particularly around performance in healthcare, and I certainly agree that this is a very appropriate societal expectation. It does require significant change, and it's potentially going to threaten our more traditional medical persona that's defined by expertism, autonomy, and more than often perfectionism. And indeed, we can expect that looking at this data is going to uncover some lapses or some variations in what our doctors' professional practices and behaviours are. So the question we have is, how are we proactively going to use our organisational systems and processes to ensure that our medical colleagues are held accountable for this professionalism, despite these changing expectations? And through this, we can ensure that our healthcare systems that they work in can thrive. One of the solutions about enhancing doctor engagement is employment. And there's no doubt that effectively implemented HR systems are certainly a way to achieve this. But the reality is that a lot of organisations simply don't have the capacity to employ their doctors. So we need to look to other systems such as accreditation and credentialing systems that are underpinned by things like bylaws to see how they can be used to achieve this same outcome. And there is no doubt that they can, but they do require a number of essential elements to be used in these systems. I've described here three elements that are required. And the first is the essential foundational ones, those that relate to compliance, to ensure that we've got appropriate registration, that we've had the appropriate training, qualifications and experience, we've got the right insurances for the scope of practice we're going to undertake in that organisation, and we're transparent about the declarations about sanctions, limitations, complaints and investigations. That's the foundational piece. The next two pieces are what I call the enhancing and cultural components. And these are closely tied together because they talk about the processes and the people, conversations and behaviours that are really essential to make those processes effective. They relate to particular periods of time that are critical in that relationship between our organisation and the doctor. The first of those is about the onboarding time, when we have got the opportunity to set the expectations, to have clear conversations about what we expect and to set up for a trusting long relationship. We can talk about what clinical practice standards are required, what behavioural standards are required. We should discuss at that time about how we will monitor people's performance, what data we will use, what processes they will be expected to participate in for peer learning and quality review. And finally, setting them up to understand that we're going to let them know when there's variation or when there's issues that might arise so they can attend to those and they can understand what's going on at the earliest opportunity possible. The next period I wanted to talk about was the first 6 to 12 months of when a doctor is working in your organisation. Just like a probationary period of employment, this is a critical period of time that can be used to nurture and develop the relationship between the doctor and the organisation. It's the time to ensure that they're connected to peers, that they're connected and they understand the workings of the clinical units that they're to work in. They can complete any essential learning that you want them to do. And there's general check-ins on how they're going. It's also an opportunity to just experiment with any early nudging conversations if they're required when it's noted that a doctor is not quite following the expectations that you'd asked of them. It's an opportunity for that doctor to understand that you're going to talk to them in a very respectful way, in a timely way, and to give them this nudge so that they can be made aware of any concerns that might have been raised. Critically, it's also important at this time, if they do have a feedback conversation, that you understand and you listen carefully to their response, because this is a real indicator as to how they might respond to any challenges in the future, and maybe such a flag that at this time you might be deciding that this doctor's behaviour might be sufficient enough that you are working on an exit strategy at this very early time. The third time is about ongoing, and this is ongoing monitoring that's required. You need to set up processes for what data you're going to use, what committees or review processes you're going to use, how your doctors and your leaders are going to be involved in those conversations, and what expectations there's going to be about what to do with the data that's looked at and considered. Importantly, in this time, it's really important to think about indicators that describe both lead and lag. And we traditionally use a lot of lag indicators in healthcare. We look at clinical outcomes, we look at adverse outcome data. They're very helpful, but they're outcomes that have occurred in the past, and we have little opportunity and levers to pull on changing those outcomes. So it's important to have described in that system and those processes a set of lead indicators that are more about processes and might include things like compliance with clinical guidelines, or they might be complaint data or co-worker behaviour reports that might be involved in your governance systems, or they might be even operational data like OT start times or length of stay. The reason these are important is because it gives us a bit of a heads up about any deviations or variations in practice that might occur. And it gives us the opportunity to dig a little bit deeper to find out what's going on, because these are the things that might impact future delivery of safe care. The conversations about variation that might be identified through data are really important, and they need to be executed in an environment of psychological safety. They first and foremost need to seek to understand and then to support reflective practice, new learning, and practice change as the outcome. As a final comment, I wanted to make the point that these skills are sometimes the skills needed to actually execute these sometimes difficult conversations confidently and transparently are essential and need deliberate teaching and practice. The conversations that we have will set the tone of learning and not one of blame. Without them, our ability to improve will just not occur, and we'll fail and we'll do no more than survive. So thank you for listening to my introduction. I'm happy to send back to you, Liz, now.
Thank you very much indeed, Claire. And also a reminder to everybody that you can post a question which will form some of the basis of our panel discussion later. So I would encourage you to use that facility. I'm now going to hand over to Professor Mark Hamilton, who is the Chair of Medical Subspecialties Institute at the Cleveland Clinic in London. Mark, off you go.
Thank you, Liz. Next slide, please. So as an introduction, I'm a gastroenterologist and a physician, and 26 years a clinician and consultant in the NHS, and now full-time with Cleveland Clinic London. I'm an active practicing clinician. 70% of my work is on call and at the front line and in clinics, but I'm also the responsible officer for Cleveland Clinic London. I'm the clinical lead for safety, quality, and patient experience, and I lead the Institute of Medical Subspecialties. Next slide. So if we're thinking about transparency in healthcare, I thought I'd start by just saying what we've done at Cleveland Clinic London and how we've had a very unique opportunity, certainly for the 7 years I've been involved in this project and before we had a brick put into place for the hospital, to take what's best about UK and London practice, but also to be able to design in methods of improving transparency and thinking about what it means and looking at our internal structures. Next slide, please. So we have a really unique opportunity with Cleveland Clinic. As you know, this is a global healthcare campus with platforms now across the US, Canada, the Middle East, and now in London. And this gives us a very unique opportunity, not just to be a 200-bed hospital in London, but to be part of a wider campus of excellence. And I think we all know that if in your US you wanted to go and have medical treatment, you go to Cleveland Clinic, go to Mayo, you go to Johns Hopkins. Why? What have they done? What have they done about the way in which they deliver medical care? They're the same sort of doctors as us. What have they achieved? And this for me was one of the really exciting parts of this role. Next slide. So we're more than a very new hospital with state-of-the-art equipment in London. This whole development is about something that's very different, and I think really goes to the heart of what has been at the forefront of debate with problems and challenges in the private sector, actually across all healthcare sectors, and particularly with things like the Cello and Patterson cases, which we all know about. Next slide. So what is that secret? What's the culture? What attracted me to Cleveland Clinic? What makes me think that there may be other ways in which we can share learning across healthcare organizations to improve this? And in the private sector, whether you're a small or a large hospital, as you know, most hospitals just take the doctors that have practicing privileges, they look at what they do, they think about what they do with them. And we had the opportunity to start from the ground up by appointing institute chairs who led each of these types of institutes and recruited doctors not for the size of their practice, not for what they've done, but for their culture, for their vision, for their wish to be part of a multidisciplinary team. And that really was the most important part of this. It also allows you to have a clear understanding of the scope of the doctors that work within your institute. And it allows you, when you're looking at low-level issues and problems, to have a very early governance structure. If you're the surgeon leading a group of other surgeons, they understand what they're doing. And this is really very unique and different to other models. And I'll touch on the employment aspect of this in a moment. Next slide, please. This has also allowed us with transparency to build something that we can tell patients we have that often they ask us about, what happens if it goes wrong in the night? What happens if it goes wrong at the weekend? And this is just one screenshot from our digital on-call system to show the depth of on-call we have across all of the specialties, similar to a large NHS teaching hospital, with transparency about the roles of doctors between their private and their NHS commitments, which I'll return to in a moment. And to give you some idea on the right side, the depth of subspecialization, even in anesthesia, whether it's cardiac or neuro. Next slide. So what do we mean about transparency? Well, I think there are lots of different directions in which we can be transparent. The Cleveland Clinic, and when you walk around the main campus in Ohio, everything says patients first. And I think in some parts of healthcare, we've perhaps lost sight of the fact of why we're here. We're there to be compassionate, we're there to look after our patients and to be able to communicate with them what we do in the most transparent way. I think we have to be transparent within our teams and within our organization and within the governance structures of our organization, but it goes further to our regulators, to our payers, and really for me, a very important part of this, cross practice and out to the NHS with the doctors who have professional footprints in both sectors. That has to extend to governance around the scope of practice, and I mentioned briefly how we do that within our institute structures. And many of you may be familiar with the fact that Cleveland has a reputation for having league performance tables for doctors. Now, there's always a criticism about how do you say the doctor with a 1 in 10,000 or a 1 in 100,000 death rate is the better one. Sometimes this is actually for looking at internal performance and judging doctors internally so that they raise their standards. It doesn't necessarily always have to be external. And employment isn't everything, but in some ways it is in the private sector, because if you bring together teams who are employed, who work like they do in the NHS, who have a culture that shares the way in which they deliver patient care, it removes some of those dynamics of you're only taking my gallbladder out because your salary is dependent on it. In fact, I can say I'd rather Dr. X took out your gallbladder because he's better at it than me. And I think that has changed some of the ways in which we're able to communicate with our patients. Next slide. Cleveland Clinic, probably 15 years before we did appraisal for doctors to contribute to revalidation recommendations, have been doing an annual professional review, and we've duplicated this here. And you can see in the middle of this Venn diagram, there are many aspects of a Cleveland APR and medical appraisal that share similar goals, but nobody in my 25 years of private practice ever took me to one side and said, how do you wish to develop? What are your challenges? Where are you going? That only occurred within my NHS role. There is in a Cleveland APR a little bit of job planning, but this gives us a superb tool for making sure that those who are connected to the NHS for their appraisal are really doing a whole practice appraisal with transparency about their scope here, with data, with analytics, with knowledge of what they're doing. And I've met all the ROs and medical directors around London to ensure that we're sharing those lessons so that both sectors know exactly what is happening. And sometimes that transparency in the current market is not always there. Next slide. We've developed a number of strong internal governance structures that address many of the things that we've just heard about, because how do you do this? How do you make sure you pick up low-level issues, that you recognize when there are issues around conduct? And we have a number of committees that are transparent between each other, that I as RO have oversight of what's happening, that report to me, that where I report externally, as you know, to NHS England and discuss with RELA at the GMC. But we have a physician conduct committee that if there are issues that can't be dealt with within that institute structure, can be escalated to a physician conduct. We believe that the wellness and health of physicians is important, so those who have challenges, physical or otherwise, can be supported through our physician health committee. And there are a number of ways in which this can contribute to the well-being of doctors within the organization. Next slide. We also have within our institute, so this is an example within my own Institute of Medical Subspecialties, a system for looking very strongly at our governance, our incidents, how our doctors are working. It's the first time in our independent sector work where I've worked with a team that replicates what I have in the NHS. I have 42 consultants that I work with in our institute. They all contribute actively to the governance structures, to the discussion, to our monthly M&M meetings. And importantly, we feed this out to the wider organization and outside of the organization where that transparency is needed. Next slide. And so really, this is my last slide in commenting on this. For me, the most important thing about all of this is that patients remain at the front and center of what we do. But how do they decide where they have their treatment? How do they know where that treatment is going to be best? People go from Texas to Cleveland Clinic in Ohio, which is a long way, to have their hip replacement because they know that the metrics and the outcome and the data are accurate and tell them that's where they're going to be well looked after. It isn't about employment, it's about multidisciplinary working, it's about culture, it's about working together, it's about having an open and transparent internal culture and strong governance. And I think this is one of the strengths of the model that we have here. And as we just heard in the first talk, it's about training and support to achieve that. I have not encountered such leadership training in any of my previous roles. We have training in high reliability for the organization. We have strong training for medical leaders around complex conversations, challenging conversations, how to support doctors, how to do this well. And the expectation is that this is not just learned on a previous job, but this is a skill that you can train. And as a digital hospital using the first electronic record system in the independent sector, we have strong internal analytics that tell us what we're doing, that I think eventually will allow us to provide, as we become more active over the coming months, robust external data so that patients can say, where should I go and have my bypass done? I can see that this is a hospital that has the best outcomes. Thanks very much for your attention, and I'll pass you back.
Mark, thank you very much indeed. I'm already seeing an emerging theme around culture, which I'm sure we'll explore in more detail later. So next, we're going to move on to Dr. Rob Hendry, who's the Medical Director for MPS Partnerships. Rob.
Thanks very much, and good morning, everyone. It's a pleasure to be with you today. I'm Dr. Rob Hendry. I'm the Medical Director and Responsible Officer at MPS, and my team provide advice and support to members around the world, and we therefore get privileged insight into what happens when things go wrong in medical care. We also work very closely with Clare Morgan and her team at the Cognitive Institute on risk prevention initiatives. So really just building on what Clare and Mark have been talking about, I've been thinking a little bit about transparency and what we see as ways forward. As mentioned, as part of your credentialing and ongoing monitoring of your staff, you will come across various issues involving complaints, claims, and so forth. Now, in fact, in their careers, the vast majority of doctors will actually have relatively few claims for medical negligence. So I'd suggest that rather than focusing on the occasional large claims, which often grab the headlines, there's much more to be gained by considering the more frequent low-level complaints clinicians receive. I think one can think of these as the equivalent of canaries in the mine, if you will. And we know that sometimes what are seen as minor complaints about physicians' behaviors, communication styles with patients and their colleagues, as well as their attitudes, can be harbingers of more serious underlying risk. Research undertaken by Jerry Hickson, who's the founder of the Center for Patient and Professional Advocacy at the Vanderbilt University Medical Center in Tennessee, found that the same 3% of physicians who accounted for 50% of the malpractice risk within that hospital also accounted for between 35 and 40% of the unsolicited patient complaints. And my colleagues at the Cognitive Institute are actually licensed to run the Promoting Professional Accountability program, which is based on the work of the Vanderbilt Center there in the US. And through that, they advocate seeking feedback on medical staff and promoting open discussions of that feedback, which comes from both colleagues and patients with the clinician, ideally in the moment, but as soon as possible, as well as being part of the annual credentialing process or annual professional reviews that we've heard about. Now, the data suggests that in 78% of situations, doctors will usually self-correct their behavior if it's flagged up to them that their behaviors and approach is out of step with their colleagues, the so-called nudge approach. And the Vanderbilt PPA results also suggest that where an intervention like this is made, the physicians can actually reduce their medical malpractice risk by up to 75% in some cases. In more serious situations, however, it's also important that healthcare organizations have clear protocols for when they require doctors to self-report incidents. And that's probably been strengthened in the UK by the importance of a duty of candor coming in. And I think the development of the revalidation process and the responsible officer role also improves this approach to promoting transparency, which I think is crucial to mitigate risk. Because a failure to share concerns about your practice, or a failure to take responsibility to follow up on cases where there have been problems, I think that means that really quite significant issues and indicators can go undetected. And clearly one of the learning issues that came out of the Patterson inquiry was the need for the NHS to be faster in terms of its speed of reporting and taking actions when concerns were being raised. Because only by having a full visibility of a clinician's practice can we properly protect patients and the organisations that they work in. If we continue to work in silos, high-risk clinicians can move from provider to provider undetected, and so something really serious occurs. And we know from around the world there have been some very unfortunate cases like that. And in the UK, I think information sharing between responsible officers can be key to this. Where it works well, I think that it can be very effective. But there is a need for adequate training and support of ROs, and that point has been made in a number of reports recently, where the information sharing really hasn't been as effective as it ought to be. So where private providers use clinicians that also work within the NHS, where they would have their RO connection, it is important, as Mark pointed out, that there's proper collaboration between the responsible officers within the NHS Trust and the private provider to be able to build a full picture of a doctor's performance, conduct, and behaviour. And where doctors are only working in the private sector and have a responsible officer there, again, it's important that that RO is given full access to the complete picture of their activities and feedback from both patients and colleagues. We've heard a lot today about the importance of culture and having an open culture within teams, and the benefit of sharing patient data, sharing doctor level performance data with patients. And I think we've touched also on how clear regulatory sightlines support better quality care as well. So healthcare organisations need to consider their risk appetite in relation to physicians that they're working with and encourage the sharing of broad range of data and information that will support the driving down of risk. I think we're shortly to hear from PHIN about the new requirements to publish more organisational data, and it'll be interesting to see how that fits into this broader picture. Because there's no doubt we live in a society that is keen to empower patients to make more informed decisions about their care. As Mark was saying, patients move across the US based on this information. And I think organisations can also use the evidence to show that lower risks and better outcomes benefit everyone. So as well as not only having fewer adverse incidents and fewer malpractice claims, it will also improve patient happiness, and patients will then end up voting with their feet, I suppose, and bring their business to the institutions that got better performance and better outcomes. At MPS Partnerships, we provide broad solutions to try to support this transparency, both through being able to provide medical malpractice insurance for organisations through healthcare protection, but also having claims and regulatory indemnity for individual clinicians through medical protection. By combining protection for both providers and for individuals through a single provider supports a holistic view of the risk across all layers within the organisation. It also allows us to deploy the appropriate risk management support from the Cognitive Institute to help institutions and individuals thrive in this new transparent environment. Thank you very much.
Sorry, I'll unmute myself. Thank you very much indeed, Rob. Some very interesting thoughts there. And our final panellist, last but by no means least, Dr. John Fistein, who's the Chief Medical Officer from PHIN. John, over to you.
Thanks ever so much, Liz. Hello, everybody. Welcome. A pleasure and a privilege to be here. So I'm John Fiststein. I'm the Chief Medical Officer for PHIN, as Liz has just said. I'll say a little bit more about PHIN in just a moment, but a bit about me. I've been working in clinical informatics for more years than I care to remember, even before possibly it was even thought of as a discipline. I originally a medic as others, and moved into the strange world of clinical informatics relatively early in my career, and have been taking that forward since. Very interesting to hear what's been said already about culture, particularly. Some of the other things I do outside PHIN are working with the Faculty of Medical Leadership and Management, where I'm one of the senior founding fellows, and indeed with the Faculty of Clinical Informatics, where I happen to be their appraisal and validation lead. And what we find in both, what I find in both of those contexts, is that all these issues about culture and about openness of communication and making sure that people aren't afraid to question their practice and to report on it honestly are really big issues that can drive patient safety. And that might sound like a slightly strange thing for me to say as somebody coming from an organization like PHIN, about which more I will say in a moment, which tends to focus on what's often called, quote, hard data, but it's a thing that, you know, we recognize and needs to be this sort of soft intelligence about behaviors and cultures really needs to be very much at the forefront in any of these conversations about transparency. So a little bit about PHIN. So PHIN actually is PHIN, as you can see. It stands for something like the Private Healthcare Information Network, but really our main role at the moment is as a curious thing, which is the information organization for the Competition and Markets Authority to work within a bit of legislation which comes, it's called the Private Healthcare Market Investigation Order, and that's all about improving, quote, the transparency and the availability of information in private sector healthcare in the UK. And if you look at that long titled order, you'll see that it requires private providers to give information about a range of performance measures that we process and publish, and I'll return to what that might mean in a minute, at both hospital and consultant level about different procedures. And those are things like, how many procedures do hospitals and consultants do? How long do people stay in hospital for those procedures? What are the outcomes? Both things like patient-reported outcomes, but also some of the more adverse things like potentially deaths and infections and various other adverse events and so on, as well as information about patient feedback. So it's quite a wide-ranging mandate, and it gives us a unique position that we gather information about really quite a broad range of practice that around in the private sector that really hadn't ever been gathered before. And of course, that is furthering the transparency agenda. And what I really wanted to say, which might sound slightly strange or controversial, is that I just want to question what we mean really by transparency and ask, is this really the most appropriate word for us to use? Is it really what we mean? And I put this really to stimulate debate, really. And to be clear, making sure information is available certainly is a foundation for all the sorts of things that we're talking about supporting patient choice, about improving safety. But is it the beginning and the end of it? And I would say that actually we need to think about the whole story and say, actually, where do we need to get to? And for me, it's all about asking ourselves, what insights do we need to have about doctors, about sites, about procedures that will help different people involved in healthcare make appropriate, relevant decisions. And, you know, we deal with a whole range of stakeholders, all with their own different contexts. And I'll try and illustrate what I mean by this notion of insight by talking about a couple of them in a bit more detail. But, you know, we deal obviously with patients because the idea is that the CMA order and our role is to facilitate patient choice. Find me, you know, quote, the best place for me to have my hip replacement or whatever procedure it is, or tell me who does it. We obviously have the sites themselves who give us the data and want to make sure any performance that we information that you put in the public domain is fair and accurate, which is our guiding principle. The doctors themselves that work at those sites, other national bodies that are interested in what we do, people like the CQC that we work with, the insurance companies that fund care and so on. And each of these has a slightly different perspective on the information that we gather. And so my real question is, we're talking about transparency, or I would offer insight. The question is, is it transparency? It's for whom and why? What questions are they asking? And that really, as I say, helps us answer the question, what information do we need? How do we gather it? How do we process it? How do we make sure that it is reported fairly and comprehensively to answer some of those questions? So thinking about, a couple of the major people that we obviously are concerned with, what about a patient? What would patients be interested in? Is it meaningful, for example, to look at some of the hard end of the data, comparing, for example, specific mortality rates or specific adverse event rates between two different hospitals that might have a completely different scope of their practice? And similarly, for consultants that are practicing, even though they might be in the same specialty, their case mix might be entirely different. So we need to make sure we can put information out, certainly in a raw form, but it needs to be fair and meaningful to actually meaningfully answer the question that, Mr. Smith is better or worse than Mrs. Jones. Can we actually say that? It's an easy question to ask and a much harder question to answer at that sort of level. Taking some of the themes, though, from the previous panelists, one of the things that we can help with, certainly, and I think needs to be much more to the front, particularly in the wake of things like the Patterson inquiry, are broad questions about, well, what expertise do people purport to have, and how do they demonstrate that? Is it because they have a certain number of procedures that have been performed? Is it something about their training, about their reflective practice? Is it something about their attitude? And how do we make that visible? At a site level, I'm looking at it from a patient perspective, what are the sort of things that people might want to know? Are absolute figures useful, or is it more about the process that is in place? So as our colleague from Cleveland was saying, they monitor things very closely. To me, that reassures me, because it means there's something happened to go wrong, or indeed, if there's good practice that needs to be highlighted, that will be identified and something will be done about it. That's reassuring in itself. Almost, not entirely, of course, but almost regardless of the specific outcome that's there. So these are the kind of questions that we engage with in PHIN all the time, because we want to put information out for patients that helps them make choices between hospitals, between consultants, that informs them and doesn't falsely mislead them based on a false precision sort of argument. And I'm focusing very much on the sort of the hard end of the data here, because I'll be honest, we have less insight into the softer end. We get some information about feedback, but I personally really agree with what everybody else is saying about the insight into the behaviors and attitudes that that individuals exhibit, because that is as important and sometimes even more important than some of those harder outcomes. Thinking of another perspective on this, I'm not going to go down all of them, but just thinking about a perspective from doctors themselves, whether that is an individual clinician or whether it is somebody who is a medical director or responsible officer for an organization. There are two sides. Practice needs to be represented fairly and completely, showing experience across all contexts, and that's something that PHIN really can help with as we have this comprehensive picture. But also from an organizational perspective, it's probably a good idea to know, as a couple have said already, what the whole scope of practice that is being performed by a particular clinician is as well, so that they can judge the performance in their own particular organization in the context of everything else that they do. So, really just to wrap up, I was just saying, that there is a lot of information that's potentially out there, and I think we should focus really on, the insights that are most relevant for each of these different stakeholders and that can be gained from this information to ensure that ultimately patients are reassured that the care that they're getting is as good as it can be, and that I think they're able to ask appropriate questions about that care. So just one story about that. We in PHIN a couple of years ago now started publishing very, very gross figures about patient-reported outcomes for hips and knees. So not even going into the detail of questions and detailed outcomes, but broadly saying, well, you know, in some sites, sometimes when you go in for a hip replacement or a knee replacement, most people get better, see an improvement after the operation. Some stay about the same and some get worse. And even that was a useful piece of information for patients, because it surprised me to find out from some of the focus groups we ran that some of the patients thought, well, actually, you know, I'm going privately for an operation, so I'm going to be skipping and dancing automatically. And that in itself provoked some questions and conversations that might have probably should have happened anyway, but it made it explicit so the patient could take a more informed decision about what they were considering. And just finally to say one thing about culture, I think an interesting question perhaps to debate further is there's a very slight tension between openness and fostering positive cultures. And one of the things that, you know, we are very clear about at PHIN is that we want to make sure that information that we publish is fair and is put out with an appropriate context, because the last thing that we want to do, and I think there possibly is a little bit of reluctance when people hear the word transparency amongst some of our colleagues still, unfortunately, because they see it as an opportunity to be blamed unfairly by things because their names are associated with, quote, something that has gone wrong. And I think the more that we can all do together to foster the culture of more transparency, more availability of information when used appropriately is better for everybody, the better care will be for everyone. So that was what I wanted to say. So thanks for that. I think I'll hand back to Liz now, do I?
John, thank you very much. For me, one of the themes emerging is that there are so many multiple stakeholders in this, and we are also now in a world where the consumer, the patient, their families are actively seeking information from so many places. So thank you for challenging the concept of transparency. I would encourage our audience to throw some questions at us. I've got a couple to kick us off. And the first one really comes back to culture. We've talked really about consultants and doctors who have reached the peak of their career, or the peak of the start of the the second part of their career. One of the things that intrigues me is culturally, do we in the UK embrace this whole theme through medical training? And at the point when the clinicians are moving through the system and then get their spurs, they're appointed as consultants, they move into a different sphere of working. But I'm really interested to know thoughts on whether we do cover this in medical training or whether we should. With the assumption that some clinicians will want to move through to become consultants and go into private practice, others will not. I'm going to ask all the panelists, but maybe I'll start with Mark, and then we'll go around.
Well, it's a very interesting question, because I'm not sure that the answer to that is known and across all areas in which people are trained. One of our interests here at Cleveland Clinic London is to be at the forefront of trying to offer training for doctors in training and junior doctors, which is not traditionally something that's occurred within the independent sector. In fact, if I think back to my own experience, I discovered private practice existed when I became a consultant, and you were faced with a choice as to whether you wished to do it or not. And it really hadn't come up on my radar at all. So I don't think the ways in which our careers as physicians might develop, and the multiplicity of directions in which they could go, both clinical and non-clinical, is something that's embedded in. We're training the doctors and training them, I think, well to do what they do clinically. I've seen a change towards people expressing an interest in leadership at very early stages in their career, which I certainly don't remember 40 years ago when I was doing it. And I think there are greater tools for facilitating and training people in this. But I think the answer is to whether we look at our healthcare system as a complete and a whole, and whether we train everybody in the interactions across the different parts of healthcare, whether it's Royal Colleges, whether it's the independent sector. I think there's room for improvement, and there are probably opportunities in that as we move forward. And perhaps all of these conversations that occur around what is quite a significant part of our healthcare sector, and that's the independent sector, will become a more transparent conversation, because it's certainly not always talked about and certainly not in educational fora.
Thank you, Mark. Rob is nodding, so I'm Rob. You get the next attempt at giving some insight into your thoughts on this.
Thanks very much. And I think it really is an interesting question, because I know a lot of medical schools are having to think about quite hard what are the skill sets that the next generation of doctors are going to require. You know, what skills will you need to be practicing the year 2060, and it's probably not being able to memorize a lot of stuff, because you can get information elsewhere. And I think, as Mark says, the way healthcare is going to be delivered is very much going to be team efforts. So I think it's timely, and again, I think it's quite interesting for the regulators like the GMC obviously have a responsibility for overseeing undergraduate training, and I think there's a real challenge there to a great opportunity to improve the expectations from the students. So we're bringing all these very bright kids, but trying to actually give them some insight into what they, what skills and attitudes they'll need to thrive. I think is something to be looked at. So great opportunities, and again, as Mark says, people seem to be interested in the way healthcare is organised in a way that I don't think used to exist. And it may well be that that's been one of the silver linings from the large cloud that was COVID, because suddenly everybody within the healthcare sector was having to look at, how do we make decisions? How do we organise healthcare? And the fact that the world is very much more interconnected than was ever thought about before. So I think it may well provide quite a significant nudge into looking at how we educate the next generation.
Yeah, and I think that leads quite nicely into Clare, into your area of expertise and your thoughts on that subject.
Then we've got you on.
I mean, historically, there's certainly not been a focus at all on the non-technical skills. There's been a lot of focus on clinical skills. But I do think that there is a great awareness of the need to rebalance that. And certainly our organisation not only works with MPS, we've got quite a large business here in Australia, and we've started here 20 years ago. We work with professional colleges now extensively with the junior trainees in delivering our programs around communication, in their leadership groups. They've got, as emerging clinician leaders, we're working with them extensively to support them around the difficult conversations and around leading conversations about variation, etc., which is really, really inspiring to see. And my personal experience is I'm currently a chief medical officer in a large organisation, and I'm watching that generation of young consultants coming out, their different approach to teamwork and their ability to sort of raise questions more clearly and more rapidly is really inspiring, because I think those attributes they are coming through in the training. I think society is teaching young people to do that as well. I mean, we've just had these massive campaigns, Me Too, and we've had Black Lives Matter. I mean, that's certainly really very coming through in our junior doctor training surveys, where they're raising concerns about the behaviours that they're seeing in their more senior supervisors and clinical colleagues. And I think that that's a good sign to me, as now they're looking for solutions. They're willing to be part of the education and training that we're adding into the system, and they're ready for it. They really are. So I'm very excited about the next generation that are coming through. They're much smarter than what we saw, I think.
Claire, thank you. And actually, you touched on the interconnectedness of our world. We have you coming to us from Australia, Mark Hamilton, representing an organisation based in the US. It feels as if there is more opportunity now for global learning and sharing of good practice that didn't previously exist. Finally, John, I'm going to come to you for some brief thoughts.
No, thank you. So they'll be brief, and really, I'm going to give a couple of thoughts. I'll declare my interest in this, and I'm wearing not my PHIN hat, really mainly, although as you say, it's all interconnected. So it so happens that I am the leadership and management theme lead in Cambridge University in some of my spare time, as part of the wider professionalism course. Also do bits of law and ethics as part of that course, as well as a few other bits around safety too. So again, all these things are interconnected. I mentioned my role at the Faculty of Medical Leadership and Management. So I also happen to chair for them the accreditation panel for medical students. And what we do in the faculty is we accredit medical schools about how well they meet a thing called the Medical Leadership and Management Indicative Undergraduate Curriculum. You can see I like working in areas that have ridiculously titled documents. The whole point about that, though, is to say that, look, leadership, these behaviours are things which are, I think that there was the FMLM view, my view particularly, is that there'd historically been this view that leadership's a thing that you kind of learn when you're later on in medicine, and all the skills and competencies that are there are things that you learn when you're the medical director. And that obviously dangers in that, because early trainees focus on the technical skills historically, and then suddenly they, the Peter Principle, find they've got to run teams and deal with people and so on. And that is a complete fiction, because all these behaviors, if you look at the domains in the leadership frameworks that we use in the UK, and they are the same as those everywhere else, really, it's all about interpersonal skills, working with interdisciplinary teams, setting direction, managing services effectively, all centered around delivering better patient care and being more intelligent about what we're doing about it. So there's definitely a culture change here, particularly in the wake of things like the mid-staffs incidents, and even things like Patterson and so on, to say, look, actually, this is a conveyor belt that needs to start early, people thinking about these things more generally. So I would hope, I say, wearing my FMLM hat, really, that this becomes something which is, it always was embedded in medicine, but it's explicitly embedded in medicine as a set of skills and behaviours that all doctors need. Apologies, I'm being parochial, it's UK and doctors. Of course, that applies to all the other professions that are involved as well. So I think it's little green shoots of something that are there. And of course, the wider context of the whole sector, private and the NHS, and how that interrelates and how systems work is all part of that as well. So with luck, things are changing.
Yes, I think if I reflect on my introduction from 40 years ago, things have changed a lot, which is good. I've got a very specific question for Rob from the audience, which is actually entwined with a pre-registration question that we had. The specific question is, do you believe that consultants, hospitals being transparent with the patient experience feedback reduces their risk profile? And I think alongside that, we've had a question around clinical outcome data lacking previously. And are insurers now driving some of that change around clinical outcome data? So I think, Rob, if you could perhaps have some reflection on that area.
Sure. No, I think that it's a very good point. And it's certainly something we're looking at increasingly, trying to get data and trying to get the evidence that what does reduce risks, because obviously when we're trying to calculate what's appropriate premiums and so forth. So I think there's some quite good evidence that where people are more transparent and tackle these things head on, that there is reduced claims. And certainly, I think there's been some quite good evidence, particularly again from the States, who I think maybe ahead of us in some of this, that early intervention, where there have been adverse events, reduces the risk profile. And we know from other work that where patients feel that there's a lack of transparency, a lack of candor, that actually drives up complaints and claims. So that's a negative impact on the experience. So the data, I think, is starting to come out to show that, but we're obviously very keen at MPS Partnerships to work with healthcare organisations to gather that and to share information to look at the risk profiling And I'm sure that's the direction of travel. I don't know, Claire, if you've, because I know you work with quite a lot of organizations on exactly this point in trying to help them reduce risk profiling. Again, I think we've just got you on mute.
I think that's a fair description. I think there's a lot of processes. The adverse events in the sort of medical claims are right at the pointy end. There's a lot of other processes that sort of start right back at the beginning, like we talked about, the behaviours and the systems and processes that people work in, that I think are the areas that we should be focusing on, because there's a lot of opportunities there before we get to the sort of the very pointy end, if you like. And the other thing is, you know, we look at safety systems 2 theory, we really should be looking at all the things that are going right, because there's a lot of activity in healthcare that is done fantastically well, despite the complex system that we're working in. And we tend to, you know, if we look at our sort of medico-legal systems, they often focus on a very small percentage of what's going wrong, rather than trying to identify and celebrate what goes right and learn from that. And I think that's what we do. We need to do a lot more of, to really, you know, embrace that, and just to learn how to spread that and share that, and make certain that all our clinicians and our teams understand that.
I'm going to come to John and Mark just very briefly on that point. I don't know whether either of you wanted to contribute anything. I have another question for you, Mark, so you may want to.
I mean, I was just going to say just a very brief thing, you know, about it. I mean, I don't have anything particularly extra to say, other than, you know, there is obviously a change of responsibility which goes through clinical practice. You know, as individual practitioners, we're responsible for our own practice as well, and a whole range of levels, as well as the organisation. So, you know, I think we shouldn't really forget that. And, you know, the way the legal system works, you know, if something happens that's bad to me, I should also declare that I am a lawyer too. Apologies. You know, I can choose to sue whoever I like, and then it's just a case of how that chain goes. So I think, you know, there's no necessarily absolution because of the process, but equally that shouldn't count against transparency.
Okay. No, thank you, John. Mark, I'm going to start with you on the next question, because you're part of an employing organisation. And the question is, to what extent does the employing organisation remain liable for the physician's actions or care after they would have complied with all the governance requirements and fully implemented the function of the responsible officer? This need for clarity is necessitated by the insistence of some private medical insurers to hold the employer liable, accountable for the behaviour of the consultant's private care activities. It's quite complex. I don't know, Mark, if you could perhaps unravel a little bit of that.
It's an interesting question, because there is, as you know, not a wide employment of consultants in the private medical sector. There are a few who have followed something like a similar model just around employment. But this is why I say that, particularly at Cleveland Clinic, employment is just the way in which you contract with the doctors who work here. It is so much larger than that. It's about the culture, the team, the multidisciplinary working. And I think what's been very different about having a team of doctors who work together, and I remember on our first day when we opened, the sort of sense that everybody in the outpatient building and everybody in the hospital was on the same team, a bit like my experience within, you know, a really good NHS trust. Whereas I spent the last quarter of a century working on my own, and those complaints come to you and you're on your own. So part of this is that your recognition at the moment with private medical insurers is still an individual one. So you are recognized by those insurers to deliver care. Your license is obviously your license with your regulator, the GMC. We provide for our employees their medical indemnity, as you would like with Crown indemnity within the trust. But there's still an element, as John has said, that an individual consultant's behaviour, what they do, is in fact their responsibility, their license, and how they function. But I think what we've seen is that there's a real opportunity here when you have this sort of structure, you have a team structure, you have reliable analytics, you have reliable data, because actually I think the concern for most physicians is not publishing what we do and how we do it, but making sure the data is actually correct and that is what I've actually done. And it's my data and it's not related to someone else. And in gastroenterology, we've supported for 20 years the publication and examination of our data and our completion rates and our complication rates. We're used to it. That's just simply what you do. And in fact, there's no pushback. It's really around the quality of the data. So I think this has allowed us to interact with insurance companies in a way I've not experienced in the rest of my private medical career, to be able to provide them with reassurance about internal governance and how we will deal with scope and issues and early intervention if there's a problem around someone's individual practice. And when it comes to it, or when there's a complaint, we as an organisation will support that. But I think, I'm not a lawyer, but when eventually the liability is ascribed to an event, then some of that still may be the consultant.
Thank you, Mark. Rob, any thoughts from the MPS perspective on that topic?
Yes, thanks. I mean, as Mark says, the situation is much simpler where people are employees because there's a clear sort of master-servant relationship, as it were, there. What I think is interesting as an extension of that is the increasing expectation, I think, by the courts. I'm interested to get John's views as a lawyer, but an increasing expectation that where doctors are not employed but working within a private healthcare facility, that the hospital, the management of that does have some responsibility for what's going on within the organisation. And the days, certainly one thing that came out again from the Patterson inquiry, loud and clear, that the days where the private healthcare provider could say it's nothing to do with me, it's all the individual responsibility of the consultant, has gone with the development of, I think what the lawyers would call non-delegable duties, that you do actually, if you're offering private healthcare and you're bringing in consultants to do the work, that you do have a degree of responsibility for what's going on. So I think that's been picked up by most of the private providers, and is driving the need for them to have better insight into what's going on, better data on the performance, and where there are issues that they're seen to be taking action rather than just simply providing facilities for them to work in. Sorry, we've got you on mute there, Liz.
Sorry, I don't know whether Claire or John have any thoughts specifically. I've got a couple more questions, which I think we'll then wrap up after, which are actually connected, so we can probably roll them into one.
I'm good.
Okay.
Yeah, I've got a comment, but you carry on, Liz, because it's better that people get the chance to ask, isn't it?
Yeah, so two remaining questions, which I think we can roll into one. What action would you like to see from regulators to steer organisations into fostering a culture where staff feel able to report patient safety incidents and where doctors routinely gather and report on treatment outcomes? And I think that then feeds into the last question, which is whether the panel believes that non-consultant members of medical teams feel sufficiently empowered to raise concerns concerning practice of consultants. Have we managed to lift the veil on the God syndrome? And that maybe takes me back to where we started, and the hierarchical approach. So have we genuinely moved on, and does the culture enable other members of the teams to properly raise concerns? And we'll make that our final question.
Well, can I start with that one, Liz?
Go on, John.
Because I think others probably have more insightful things to say directly related to it. But I mean, I think that both of those questions very nicely draw together all of these themes about culture, about risk in the first question, and about your question, Rob, about the legal position, as it were. So I mean, the bits of law I tend to look after about information governance and tedious things like that, rather than suing people. But what I would say is that for all of these things, when you go to law, that something's failed. Yes, if you need to sue somebody. And what I was going to say in answer to that question really was the answer to this one, which is it's all about the culture, isn't it? And we've been saying this repeatedly throughout what we've been saying today. Everybody in an organization that is delivering healthcare, you would hope, has some responsibility to a greater or lesser degree to raise concerns about something which they aren't happy about, and they should be able to do that in an open way where they don't get any sort of come back. Obviously, if people are raising malicious complaints, that's a different matter, but they should be comfortable and free to do that. And there have been cases in the NHS where mid-staff's an aside, and I think there was another trust that one of the senior leaders tried to, I think, virtually fingerprint various bits of evidence to work out who's that. And Rob, you're nodding. I'm not making that up completely. Just
No,
work out
it's
who was
absolutely
Sadly
true.
true.
who was the whistleblower, which is just a kind of an extraordinary position. So does that answer the question about whether it's the consultant that is being godlike or the organization that is being institutionally arrogant and, in that case, egregiously stupid, shall we say? Clearly the culture needs to change. And I think the fact we're having that kind of conversation at all now has to say that something is changing, and the more that we can do that. So, I've already said my piece about getting the medical students thinking about these things early, and that needs to be across all the professions. What do we do to change behaviors right now? Can the regulators help? This is a thing that we struggle with. I've had many conversations with the medical directors of different private organizations, and often it comes down to, how is this consultant behaving? There's some soft intelligence on the ground about their attitudes and so on. And I was speaking at a conference earlier in the summer with the CQC, and they were talking about, on the same panel, and they were also thinking, how do we gather that soft intelligence? Because is it the sort of thing that can be reported on directly, or how do they gather it fairly to make sure that to answer both of those questions, that the godlike behaviors aren't encouraged, shall we say, when they're destructive, but also that organizations themselves have this kind of open reporting framework, and they're very difficult questions to answer, I think. And, I think we're still generally struggling with it now. I'd be really interested to hear how others have handled it in their own organizations, because
Liz, can I just comment on the
Yes,
work of our company has been doing education programs and culture change programs for many years, probably more than 10 years, in speaking up for safety and in accountability and professional accountability programs. We've implemented these in over 300 organizations across the globe. And I can say that you can teach non-consultant staff to speak up for safety, for staff safety and for patient safety. You need very deliberate cultural change programs that teach everybody these skills. Giving them an e-learning module is not sufficient. People need to practice. They need to feel safe to practice. But we have been successful in many different cultural settings in Asia, and in the Western Hemisphere as well. So I think, there is a cultural background that sometimes can make that tricky. But I have to say, some of our most successful programs have been in Singapore and in Indonesia. So I think, yes, you can do it. It's a very deliberate journey. It doesn't happen overnight. To train 2,000 or 3,000 people in an organization, from everybody from the CEO down to the cleaner, is what we've sort of undertaken to do with some of these organizations. It's a massive commitment, but it is very successful, and the outcomes we get in terms of being measured by staff safety surveys really indicate to us that staff will speak up, and the incident monitoring and the numbers of incidents being reported do increase as a consequence of programs like that. So it is possible. In Australia, I have to say, the regulators here, both from the training as well as from the hospital accreditation, have done a lot in helping us to shape these incident reporting programs, as well as the doctor data, monitoring and measuring and talking about variation. So I think there is a role for the meta regulators. It's just that all parts of the system have to work in sync to actually deliver what we're asking in these two questions.
Thank you, Claire. Mark, some thoughts from you and the Cleveland Clinic.
Yeah, just a few brief comments. I didn't mention when I was talking earlier that we do in fact have medical student rotations from London Medical Schools through Cleveland Clinic, and we're the first independent sector hospital to do that. So that's been really interesting, exposing them to a different type of healthcare system. That's been very rewarding. I think if you come from an NHS background, we are so used to a flat hierarchy these days, working alongside nurse consultants, nurse practitioners, allied health professionals. The concept that the consultant is God is not really part of my experience of being a consultant in the NHS. And to bring that through into the Cleveland Clinic culture, where we have really empowered and fostered a speak up culture here from all members of the teams, whatever systems are used for that, so that before you join an organization like Cleveland Clinic, you might be Dr. Famous doing something or other. Once you join the culture of this organization, this becomes about the patients, it becomes about the teams. There has to be a sense that we're all pulling in the same direction. And this is now the patient being seen within that culture and that organization. And I think that's what I've seen across the global campus. I've met people who really are the best at what they do, but they're very humble and they're very much members of a team, recognizing that they're good at what they're doing and their outcomes because they're delivering this, because the team is functional. And I think that sort of bit then focusing on the other question, you can regulate everything, but actually I think it's also up to us as hospitals to be able to offer solutions to regulators. And the two things I've seen here is that we've had a very strong onboarding culture. My onboarding has consisted of there's the ward and there's the patients and get on with it and here's your login. Whereas we had a full 1 week for every consultant who joined us to really bring them not just into the digital platforms, but into the culture, into the regulation. We had the GMC do a half day with us around all the aspects that we as both the regulators and the organization feel are positive ways in which we develop that open and that culture of speaking up. And I think that the thing I mentioned earlier on in high reliability training is something that spills out into that to empower all of the staff, whether they're nurses. That's why I like the term we have here for caregivers, whether you're the cleaner or you're the nurse or you're the cardiac pump technician, you all share a role in patients' outcomes and their experience and their journey through the hospital. And using high reliability tools, which, as you know, run aircraft and nuclear power stations, but also hospitals, gives a set of tools that everybody in this organization has that training that allows them to use those tools in a very practical way on a day-to-day basis to ensure that patient care is safe.
Thank you, Mark. I don't know, Rob, if you've got anything to add.
Not really, other than to say I think it's a really interesting question about how do the regulators support this, because I know both, this thinking from a UK perspective, but both the GMC and the CQC, I know haven't had their troubles to seek. But as they look to the future, I know both organizations are really very keen to see how regulation can promote excellence and safe practice. And I think some of the stuff we've talked about today might be a pointer to them. I don't know if there's anybody from either those organizations in the audience, but I think as we feed back to them and think about how they can develop and improve this idea of transparency and the themes we've talked about are going to be central to that.
Thank you. I'm going to wind up by thanking our panelists so much for a fascinating morning's discussion. Clearly, culture is at the heart of everything, and there are really encouraging signs across the globe that there is a shift in the way that the medical establishment, the medical profession is reflecting what it does to enable patients and others to make informed choices, which is really positive. Just as a final thing, I just want to remind everybody about the Private Acute Healthcare Conference on the 12th of October, which is just a fortnight away now. You can get more information or book via LaingBuissonEvents.com. Again, thank you to all the panelists. It's been a really, really enjoyable and informative session. Thank you so much, everybody.